Good evening, everybody. Welcome to our webinar on the Miach BEAR Implant, a scientific and clinical overview. We're thrilled to have you join us tonight for this session where we'll delve into a groundbreaking advancement in orthopedic surgery. Without further ado, let's introduce our distinguished speakers. First, we have Dr. Martha Murray, Professor of Orthopedic Surgery at Boston's Children's Hospital and Harvard Medical School, the researcher and inventor of the BEAR implant and founder of Miach Orthopedics. And then we have Dr. Daryl Osbahr. He's a chief of orthopedic surgery at Rothman Orthopedics in Florida and chair and executive medical director at Advent Health Orthopedic Institute. During the webinar, the Q&A box will be open for questions where you can type in, and we will address them at the end during the Q&A session. Dr. Murray, it's all yours.
Thanks, Mark. So tonight we're going to talk about restoring torn ligaments using regenerative medicine. These are my disclosures. As Mark mentioned, I'm a founder of Miach Orthopedics, and I'm also an inventor on patents that are owned by Boston Children's about the BEAR technology. Those are probably my most relevant disclosures. So when we first learned about ACL injuries, the treatment for them was commonly a simple suture repair, so where we try to reapproximate the torn ligament ends. But unfortunately, that procedure had a 50 to 90% failure rate, and the results were found to be no better than non-operative treatment in 2 randomized controlled trials. So that's been largely abandoned in favor of something called ACL reconstruction, which we all know and love, which has where we actually remove the torn ACL and replace it with a grafted tendon. So the outcomes of ACL reconstruction are good, but they're not perfect. So there's pain and weakness where we take the graft. The return to pre-injury level of activity is only around 63%. There's a 70% or plus risk of getting arthritis 15 years after the injury, as well as an increase in myocardial infarction later in life. We've been trying to improve ACL reconstruction. So there's lots of articles on PubMed. We tried different graft types. We tried putting the tunnels in different places. We've tried biologic enhancement, but really have had no significant improvement in outcomes in the past 25 years. Adolescents are particularly troubled by this injury. So 20% of patients who have an ACL reconstruction and are teenagers at that time will have an additional same knee surgery, and half of those will have more than one. There's high rates of early graft failure, late graft failure, and post-traumatic osteoarthritis. So we wondered, was there something we could do differently? So instead of trying to improve ACL reconstruction, could we do something to get the ACL to heal? Could we put a scaffold in there and try and maybe load it with some growth factors or even some cells and see if we could stimulate healing of the ACL? But in order to do that, we first had to figure out, why did repair of the ACL fail? So we know that other tissues heal on their own with or sometimes with suture repair, things like the MCL, skin, Achilles tendon, etc. So what we did is we went back and looked at different cellular and molecular events in ligament healing. And we know that after an injury, first we have a provisional scaffold that forms, then inflammatory cytokines get released, fibroblasts come in, they deposit collagen, and then there's neurovascular remodeling and infiltration, and then collagen remodels into a more precise form. We wondered, where does it all go wrong for the ACL? So we did a series of studies looking at the biology of the ACL injury versus that of an MCL or a patellar tendon to find out where the issue was. And I'm going to summarize those studies here. So when we have an MCL and an ACL and we look at their response to injury, cells and blood vessels proliferate in both the MCL and the ACL after an injury. Those cells are capable of migrating to an adjacent scaffold. They're capable of making collagen, but does a bridge form over the wound site? Well, it does for the MCL, but not for the ACL. And what do I mean by that? If we take an animal's knee and we make a small slit in the middle of the MCL and a similar slit in the middle of the ACL, leaving intact fibers on either side, so a mechanically stable defect, and we close up the knee and we go back a week later, this is what we see when we do immunohistochemistry of the defect. And this is where red is a positive stain for basic fibroblast growth factor. So you can see in the MCL wound site, the wound is filled with material that's releasing positive growth factors. But in the ACL, not only is there no red there, there's no basic fibroblast growth factor, there's actually not anything there. And what we see is that persists even at 6 weeks. At 3 weeks. You can see here the top row is the MCL going on to heal, the bottom row is the ACL with that still open gap, and then it also continues at 6 weeks as well. So what we found was that even though there's lots of good things that happen in the ACL after injury, it doesn't form this provisional scaffold. And so really there's no place for all the rest of that great biology to occur. So why is that? We wondered. So if we think about how that wound site and that provisional scaffolding forms in the MCL or patellar tendon, basically we always have fibrinogen circulating in our blood. We get an injury, the fibrinogen gets cleaved by thrombin into its sticky form, fibrin, that traps platelets and red blood cells and forms that provisional scaffold in the gap. But inside the joint, it's a little bit different. So inside the joint, we have fibrinogen that gets cleaved by thrombin at the time of injury to that sticky form of fibrin. But at the same time, we have synoviocytes that are lining the joint, and they send out something called urokinase plasminogen activator, which takes that inactive form of plasminogen that's always circulating in our joint, and it turns it into the active form of plasmin, which then can basically degrade that clot as quickly as it's forming. So we end up with a rust-colored hemarthrosis rather than a blood clot forming between the torn ACL ends. So we think that the mechanism behind the ACL's failure to heal is this premature loss of provisional scaffold. So we have the MCL, tears, blood clots in between the ends, it gets trapped there, the cells can crawl into it, produce collagen, heal the ligament. But in the ACL, even if we put sutures in it to get it to reapproximate, the gap in between the torn ends will not fill in with anything. And so eventually those ends will keep pulling on the sutures and our sutures will fail. So we think that bridging of the wound site is required for ACL healing. So our thought was, well, what if we could implant a bridge between those ends that would keep the ability to stimulate cell ingrowth and proliferation, but it would not be broken down by the synovial fluid? Could we then combine that with the suture repair to make a bridge-enhanced ACL repair? So we tried optimizing the bridge with experiments in vitro first. So this would be things where we would add certain growth factors to a scaffold and see if we could make the cells do what we want to do. But they didn't really do too much, and they were also very expensive. So we went back and said, how does it work elsewhere? Well, if we have a tissue injury someplace, we know that we talked about activating that clotting cascade in plasma. That's that cleaving of fibrinogen into fibrin. But we also know that platelets get activated in that clot, and they start to release a lot of different growth factors. We saw the FGF2 release from them, but they also release EGF, serotonin, etc. And white cells are often recruited to the wound site, and they also start to release things like MMP, TGF-beta, TNF alpha, and basically over 1,000 genes get released, or 1,000 genes turn on and off in the first few days of wound healing. So rather than trying to recapitulate all of those genes turning on and off at different time points, we thought, what if we take advantage of the normal system in blood and get these normal things to happen? Could we then stimulate wound healing in the ACL? So we began working with platelet-rich plasma, which we could tailor to what we wanted. We could change the concentration of platelets, we could alter whether it has white cells or not, and we could also figure out how do we want to activate it. Do we want something physiologic, or do we want to have thrombin in it? And so we developed a fit-for-purpose animal model to test this idea in. And so we wanted something with a relevant size, so a larger animal rather than a mouse or a rat, and also something with similar hematology, since we're counting on those blood cells to bring in the biology. And we wanted, lastly, something with relevant biomechanics of the knee. So we picked a porcine model, and in a porcine ACL transection model, we were able to validate that an untreated ACL transection doesn't heal in the pig, just like it doesn't in people. A suture repair alone was inferior to an ACL reconstruction, and an untreated ACL transection would lead to post-traumatic osteoarthritis in the same pattern as we see in our human patients. So in that model, we did a large animal study in these 30-kilo pigs where we cut the ACLs on both sides. And on one side, we treated it with suture and PRP, and the other side, we treated it with the suture repair alone and looked at basic outcomes. And what we found essentially, though, was that PRP really didn't work. So we had similar yield load in the two knees, similar linear stiffness, and equal knee laxity. And so we've gone all the way from figuring out a mechanism to making a design to preclinical testing, and now we've got to go back to the drawing board because what we thought really wasn't right. So we started asking ourselves, well, why didn't PRP work? So if we think about it, the main thing that holds PRP together is actually fibrin. So if we take something that's fibrin-based and put it into a joint at the time of surgery, when we've stirred up all of the synoviocytes and have them release, have them making urokinase plasminogen activator so that the joint is then flooded with plasmin, it's probably breaking down our PRP just like it breaks down the blood. So if we think that the fibrin is prematurely dissolved, is there something that we could combine the PRP with, or the blood with, to protect it from getting dissolved too quickly. And it turns out that types of collagen can do that. So when you mix certain types of collagen with fibrin, it actually stabilizes it against degradation by plasmin. And then we were able to show that it also stabilizes it against degradation by other enzymes like elastase and collagenase. And so it helps the fibrin clot to stay there a lot longer. So with that, we developed an ECM scaffold basically as a carrier for the blood cells, since the fibrin itself won't hold them in place. So we take our biologic wound healing system, which is blood cells and plasma, and we can stabilize it for use in the joint with this collagen-based matrix. So we know we had to be careful, though, about what ECM matrix we used, because in the past, when we've used different types of patches or collagen implants, there have been trouble with those. So typically, these are difficulties with an immune type reaction, not typically infection. It's usually a sterile immunogenic reaction. And a lot of these have to be removed because of the swelling and pain that they cause. So we spent a fair amount of time working to develop a substitute scaffold that would be less immunogenic and not cause this type of reaction. And we tested it in different places. And so we came up with this material, which comprises the BEAR scaffold. And so really the BEAR scaffold has all of its cellular material removed during processing. There's no chemical cross-linking agents because those can cause irritation, especially in the joint. And it's able to absorb and activate the blood cells and encourage ACL cell ingrowth. So we then said, okay, well, what blood cells should we put in it? We know we want to have some of the blood things in there. And what we found was that actually the way that successful wound healing happens, we need all of the cells. So when we looked at all these manipulations, we found that all parts of blood may play a role. And both in our in vitro and in vivo studies, whole blood worked best. And so that's what we decided on. We also wanted to work to optimize the suture fixation. And we found, I'll show you a diagram in the next slide, that bone-to-bone fixation was best to fix the knee, to stabilize it. But if we put a suture anchor into the notch to use that for our second bony attachment, that anchor would pull out about 20% of the time in our animal studies. I think because the cancellous bone wasn't strong enough to hold it. So we did studies like this, trying to figure out where to put the tibial tunnel, basically to restore the normal AP laxity of the knee. And what we found was that this middle tunnel, combined with bony fixation in the femur, was able to make the AP laxity of the knee the same as an ACL intact case. We also wanted to look at absorbable versus non-absorbable sutures, what type of suture to use. And it was interesting in this study, when we used absorbable sutures, the females had worse results with absorbable than with non-absorbable. But females and males both had very good results with non-absorbable suture. We don't know why that is, but we ended up electing then to stick with non-absorbable suture. We also wanted to be careful about which non-absorbable suture. So we know that for synthetic ligaments that we've used in the very distant past, those breakdown products can cause synovitis of the knee, which can lead to accelerated osteoarthritis. So we also wanted to avoid the use of high-strength sutures that may have silicone or something else in them, because those can cause upregulation of pro-inflammatory markers in vitro and also can result in late granuloma formation after surgery. So we worried that those might not be inert and might actually affect our healing process. Ethibond, on the other hand, has been shown to be inert in multiple in vitro and in vivo studies, and we've done now over 400 porcine joints, and we've never found evidence of synovitis as a result of the suture. But again, our longest time for those is a year, so whether late synovitis could develop is possible, but Ethibond's been used a lot in the joint without this type of reaction. So we thought that would be reasonably safe. So with those things, we instituted preclinical studies where we wanted to investigate the characteristics of our substitute scaffold first in vitro, and then we developed this in vivo model to test it. We used the model to optimize our surgical procedure and implant, and then moved to GMP manufacture and testing for the FDA. So this is the basic BEAR procedure. Everyone here knows what it is, so we'll keep going. So in our fit for purpose model, now we did another bilateral ACL transection case, and now we treated one side with a suture plus a scaffold plus blood cells in it, and the other side suture alone. And what we found here was that the scaffolds, when we had the scaffolds in there with the blood, they were completely populated with cells by 1 week after implantation. And these cells were these plump ovoid fibroblasts that really appeared to be creating a lot of collagen. And then by about week 4, we saw blood vessel and nerve ingrowth. In the large animal model, then the histology got better over time, and we saw restoration of the ACL histology by about 6 months. And when we look at just what happens to the naked eye, we can see that this is a pig knee looking at it from the front, and in the left panel, that's an intact ACL. If we cut the ACL and do a suture repair alone, by 3 months' time, the sutures have broken and resorbed, as have the ends of the ACL. But when we do the suture plus the platelets plus our carrier, plus that collagen-based carrier, we're now starting to see fibrous tissue forming in the region of the old ACL. When we look at the mechanical properties of that at this 3-month time point, the mechanical properties of that repaired tissue are similar to that seen in ACL reconstruction. And those mechanical results persist out to 1 year later. Which, just interestingly enough, the cartilage also was different in the 3 groups. So when we did an ACL transection, the cartilage, particularly in the medial compartment, began to break down by 6 months and was worse at 1 year, as you can see here in this picture where the red arrow is pointing. When we do an ACL reconstruction, we see similar changes, again, predominantly involving the medial compartment in the pig model. But when we did an ACL, bridge-enhanced ACL repair, we did not see those changes in the cartilage. This was very surprising to us. Because the mechanics were not that different. But when we actually measured the size of the cartilage lesions, and this was done in a blinded fashion by one of the graduate students, the bridge-enhanced ACL repair knees in the pig model did not have any significant change in their cartilage as a group, where we saw those changes both in the ACL reconstruction and ACL transected group. So with this data in hand, reasonably good data on biomechanics, as well as it appeared safe for the cartilage, we went to the FDA and asked them for help getting to a first-in-human study. So they gave us a Class 3 designation, which required a fair amount of testing. This is our team when we sent in the FDA initial application for the first-in-human study. We were able to get permission for that first-in-human study and started the BEAR 1 trial in 2015. This study was led by Dr. Lyle McKaylee. This was 10 patients who had a bridge-enhanced ACL repair, and 10 patients who had these were hamstring reconstructions. This is just a slide to show you the 10 BEAR patients in this first BEAR 1 study. So these were mid-substance tears, and all patients had a positive pivot shift on exam under anesthesia. In terms of safety in the BEAR 1 trial, this was really designed to be a safety study, not an efficacy study, but we didn't find any evidence of infection or rejection. There was no differences in the level of effusion or pain, and no significant range of motion deficit in either group. This is just our first bridge-enhanced ACL restoration patient. So on the left is just somebody else's knee with a normal ACL. And this is our patient's knee. Here's his mid-substance ACL tear. And so really the first look we had at whether this would work in a human was this MRI. And so at 3 months, you can see there's gray and some early fibers starting to form there in the region of the ACL. By 6 months, that dark center section with the fibers is getting more prominent. By 12 months, even more prominent. And then by 2 years, it's still looking very good. So this was really promising to us, seeing this in the first patient. In addition, the KT was within 1 millimeter of the contralateral side. And here I just put in a slide for the first 10 BEAR patients, all of their 3-month MRIs. And so you can see all of them have restored continuity from femur to tibial site. This is what they look like at 6 months. So again, most of the patients are getting darker fibers forming at this point. And then at 12 months, again, very similar. So in terms of preliminary efficacy outcomes, we did measure some efficacy things in BEAR 1. KT 1000 testing was similar in both groups at 6 months, 12 months, and 24 months. So basically, to summarize the BEAR 1 safety study, all of the patients at their 2-year time point, there were no significant adverse events related to the device. The BEAR was similar to ACL reconstruction at 2 years for our patient-reported outcomes, as well as knee stability in patients, a proportion of patients that had an IKDC normal or nearly normal exam. The BEAR patients did have faster recovery of their hamstring strength because they didn't have a hamstring graft. And there were more patients with a grade A IKDC physical exam at 1 and 2 years in the BEAR group. Not statistically significant, just numerically. So then that let us go back to the FDA and get permission to open the BEAR 2 trial. This was a single center RCT led by Dr. McKaylee, Dr. Kramer, and Dr. Yen. This was BEAR versus ACL reconstruction with autograft. 100 patients, ages 13 to 35. 2/3 were randomized to BEAR to help us really give us the best chance of picking up any rarer adverse reactions that could occur with the BEAR implant. The median age of the enrolled patients in this study was 17. Their median pre-injury marks activity score was 16 out of 16, and 75% of them were participating in level 1 sports at the time of their ACL injury. Our outcome measures were KT1000 testing, as well as a patient-reported outcome. We used the IKDC subjective score, with secondary outcomes as listed here. The results of this trial showed that, and I think Dr. Osbahr is going to talk about this as well, so I'll try not to steal his thunder, but we had no infection or rejection or immune reaction. And at 2 years, the BEAR bridge enhanced ACL restoration subjects had comparable patient-reported outcomes, comparable knee stability, improved muscle strength, and a re-injury rate similar to that seen in ACL reconstruction. We then, at that point, when we had good 1-year data in the BEAR-2 randomized controlled trial, we were able to attract funding from venture capital and other investors, and were able to really get the startup company off the ground at this and move things into a more commercial phase. So just in summary, in our bridge enhanced ACL restoration studies, we did preclinical studies in a large animal model. We were able to show the scaffold material resorbs and is replaced by ligament tissue. In terms of biocompatibility, we were able to do additional studies that I didn't present here, but present those to the FDA, and they accepted those as evidence of good biocompatibility of our material. We were able to validate our sterilization method, begin to get level 1 randomized clinical trial evidence. And when we got the 2-year data from that trial, that showed good patient-reported outcomes for knee pain, functional outcomes, and a re-tear reoperation rate. And so with that data in hand, we were able to, Miach submitted to the FDA and was able to get marketing approval for a new implant to repair a torn ACL in December of 2020. I'd like to just acknowledge our preclinical team that helped with all of these studies over the last 20 years or so, as well as our clinical team at Children's that helped with the BEAR-1, BEAR-2, and then BEAR-3 studies. And finally, I'd like to thank our financial supports of the National Football League Players Association, Children's Hospital through various foundations, NIH and NIAMS, and also NIAMS, which is a branch of the NIH that helps fund orthopedic research. So thanks very much to all of those funding agencies, and I'll be glad to take questions at the end of the webinar. So thanks.
All right, good evening, everybody. So I got to admit, it's always a pleasure to speak after Martha or Dr. Murray, and it's always impressive all the hard work that she did and has put into this along with her teams. Certainly, I think what hopefully everybody has left those slides with is how much effort, how much research, and how much knowledge has been put into defining a great way to bridge ACL restoration. And so I'm going to take some time just to kind of give a little bit more of the post-commercialization view and share a couple cases with everybody to give an idea of how kind of ACL restoration has changed my practice and the journey I've been on since I started. And so just to give a 2024 commercial update, there's been over 2,000 patients that have been treated with the BEAR implant. About 2,500 have been put in overall. And if you look at it, about most of the ones that have been treated within the commercialization phase have been proximal tears. And what that means is Sherman type 1 or 2 tears. And for those of you that aren't familiar with the Sherman classification, that means a avulsion type injury or one where the tear occurs in the proximal portion of the soft tissue ligament. Mid-substance tears are more Sherman type 3 or even 4 injuries that occur truly in the mid-substance. And what's interesting, a lot of the studies that were done initially, including BEAR-2, most of the injuries were actually mid-substance type tears. But as we've seen this kind of transition to a commercialization phase, which a lot of people on this call are either using or treating patients from a therapy perspective, certainly comfortability has come in more of those proximal-based tears initially, but still getting used in the mid-substance tears. The age breakdown is all across the map. We can see it's been used in young patients that are athletes, all the way up to patients over 40, which I fall in that category, where more recreational athletes, weekend warriors, and such. So again, they've been used all across the map. From my perspective, one thing I'll say additionally is if you look at from a commercialization perspective, what do I look like at in terms of tear types? Certainly to me, the location is important, but the quality of tissue is also important as well. Can the tissue hold suture? Can you direct the tissue in the right direction? There's been a lot of research that's been done showing the ACL can heal, just often doesn't heal in the right direction. And so certainly what Dr. Murray and others have shown now is that if we put the ACL fibers directed in the right direction, then often we can get healing by restoring that the mechanism for holding a clot, preventing synovial ingress into the clot area, and providing some stability at that site to enhance healing. So from a patient selection perspective, what I like to go over is kind of where my journey has been and where it's gone. Certainly, I was on a journey for a long time in terms of the ACL reconstruction not being the end all from an ACL surgery perspective. And so certainly as I've done this for the last 10 years, I've done repair and select candidates. And then in the past 2 years, I've been on the BEAR journey from a restoration perspective. So for me, where was a good place to start? And from my perspective, what I looked at was what was a good patient where I almost go into the knee and I feel like I'm taking out a lot of good quality ligament. And so that's definitely that proximal base tear. So when I talk to a lot of surgeons out there and physicians that are interested in trying restoration, I tell them, hey, there's a lot of cases to start with, but getting comfortability is really that patient that gets more of an avulsion type injury. And so you can see here, good quality ACL tissue. You can see a little bit up here that's not intact, so maybe a femoral avulsion, but maybe a little bit more of a Sherman type 2 with up to 20% of the ligament still attached. But you almost go to the other views, the corona, you can almost see lift off of the ligament, maybe just some residual tissue along the footprint with some reactive tissue at the bone itself. And so this is a great patient to start with as you kind of go down this journey, because often it can be a situation where you go in there and you see good quality tissue. And this is what I'm talking about from a clinical perspective. So we can see here a lot of vascular tissue. You can get a sense here that the ACL is buckled forward. This is the PCL for those of you that don't see a lot of arthroscopic pictures. And you can see as I go in here with the probe, I can get a sense my probe's getting in there and I'm lifting off the ligament, but I can see a little tissue, which is really the synovial tissue surrounding the ligament. And as I come over the top of the ligament, what you'll notice is there is a hole within the synovium. And if I kind of press down on that hole, you'll see some of the cyst kind of formation tissue kind of, or fluid coming out of that area. So you can see some synovial tissue, but the bulk of the ligament is getting pulled off as I retract it back. So in a lot of these cases, this won't necessarily always heal to the footprint. So a great patient as we start off from an ACL restoration perspective. So from a patient case perspective, I'll go through a few cases. And what's really changed in my practice is almost what's happened to me from a clinical perspective. When I see a patient in the clinic with an ACL injury, my approach is completely different. Dr. Murray pointed out some great information about ACL reconstructions, and it's not the end-all be-all. And certainly there are complications that happen, and it's not all about re-tear rate. Re-tear rate is one of the components we look at. But how many people have had patients that have had a little bit of nerve findings, stiffness to the knee, quad can't build back up, struggling through the rehab, or subsequently have a reconstruction and re-tear as well? And so certainly as I've kind of gone into the office now and talked to my patients, there's been so much research that's been done on the restoration and BEAR implant that I feel that patients deserve to understand and know that this is an option to treat their ACL. So when I walk into a room, I talk about the COPER program, ACL repair and restoration, as well as ACL reconstruction with 4 different grafts, including the patella BTB, quad tendon, hamstring tendon, and allograft. And as I go down that journey with patients, I kind of listen to them and learn about what are their biggest fears. How old are they? What's their activity level? Cutting, pivoting, and twisting activities that they want to participate in, and really get a sense for what is the patient looking for, what I'm not assuming they're looking for. And so along that journey, I found that a lot of patients are very interested in understanding what the restoration technique looks like and whether or not they are a good candidate for it. When I go down that realm and communicating in the office, I then try to get a sense for, hey, if you do believe restoration is the right option for you, I give them information, have them go home and think about it, and have repeat conversations about whether or not we're going to definitively go down that road, or whether reconstruction is the right option. But every patient I indicate, even where I think an ACL restoration is a good option for the patient, I will always in my consent forms have ACL restoration with the BEAR implant. And then possible ACL reconstruction with whatever graft. Because if I ever get in there, then I have the option if the quality of tissue is poor or it doesn't look like the MRI says. And in fact, some research has been done showing that the pre-op MRIs on these patients aren't always predictive of what the quality of tissue is going to look like or the candidacy from an ACL restoration perspective. And so, my first patient, how I started was a great, kind of a great candidate that I showed from my earlier pictures, that was a 65-year-old female with an ACL tear while skiing. And so often a lot of people would say, well, what about just trying to do a COPR program in this patient? And as I discussed before, I offered COPR program. The patient wanted surgery. So this is a perfect candidate of a little bit of chondromalacia, but good cartilage surfaces, a true acute ACL injury, otherwise a good quality joint. And the patient did not want to do a COPR program. And although a reconstruction can be an option in a patient of this age, there could be concerns about that. And so we can see here on the MRI some disruption of the proximal ACL. We can see here on the coronal the same thing. There's disruption at the footprint of where the ACL attaches. And so when I went into the joint, obviously you kind of look at that and you say, well, is part of it intact? Is it not intact? And we can see here it looks good quality. When I duck around the corner, the same thing. We can see the tissue is pulling off the footprint with some synovial tissue intact. And so this shows my drilling on this side. I've switched to a different guide now, and then shows me with the sutures passing and my Ethibond sutures in my setup from an ACL restoration perspective. Now, obviously, it's always, you never want to show cases that just always go smooth. Obviously, there's always some good things to show and lessons learned as you kind of go through these cases. And so this patient went back to Vail. Fortunately, at 3-month mark, did not ski, but fell. And then presented at the Stedman Clinic, where they did an MRI to see what was happening. Is Dr. Murray showed before, that's the time you get scared as a surgeon, because you're getting an MRI at 3 months. And as she showed very eloquently before, there can be further changes and improved look of the ACL all the way up to the year mark, with restoration at the 2-year, or a continued good quality tissue at the 2-year mark. And so I was a little nervous, but even it was interesting. The read from the radiology report was that it was a BEAR implant with the ACL restoration still intact. And we can see here, you can see some of the sutures going through, ACL tissue still intact. As we get to the other sagittal view, footprint that's attached, and we can see almost right here, restoration of the footprint attaching back in. And this was the drill hole that I had on the femoral side. So healing at that footprint side where there was injury that was previously incurred for this patient. And so now this patient is 2 years out, has returned to skiing and doubles tennis with no issues, which is a great result in a 65-year-old patient that obviously you'd have concerns about, is even surgery the right option? So here's another younger patient, because I wanted to show, because my practice has definitely evolved over time. Certainly with elite athletes, I have interesting conversations with the athlete as well as the team and athletic trainers to make sure I get comfortability about doing a restoration procedure. But this was a 19-year-old female with an ACL tear trying to catch a fly ball. She actually had a teammate that had had an ACL reconstruction and had a poor result. And so when she came to see me in second opinion, she was very interested in what other options there were. And so as you can see here, definitely not a Sherman type 1 avulsion injury, some injury toward the mid-substance, but maybe a Sherman type 2, could be even up to a 3 type injury. We can see as we roll through the images here, a little bit of tissue attached to the femoral side. And we can see here on the coronal, we can see still a little bit of tissue on the femoral side. So definitely more of a 2 to type 3 injury in a softball player at 19 years of age that plays in college. So obviously one of the athletes that some people might have concerns, given that it's an elite athlete trying to play college sports. So I went in there, showed a similar type injury. You can see the ACL here. I wish I had had a view of what it looked like, but it looks similar to before, but there was some tissue coming off the femoral side. Drilled both sides, and this was the setup. You can see some tissue here, but there was some tissue up here off the femoral side. So what you can see actually, oh, that got placed in the opposite direction. So this was the this was the resting position. We can see some tissue here. As I displaced it, you can see it pulls away, but there's some tissue up here. The injury was right here. But as I push it to a reduced position, you can see I have enough length of my ACL tissue to still direct it up to the right spot. And so this was supposed to be the next slide. So sorry about that. This was me doing the femoral position, tibial position, and then the setup. So interesting. The interesting part about this was that She had PT in a very rural Florida county. She was really struggling initially with range of motion. It was a physical therapist that hadn't necessarily worked with the BEAR technique before. At 2 to 6 weeks, I was already trying to get a change in PT site, but the patient declined based on the amount of distance it would take to get to another PT. Finally, at the 6 to 9 week mark, only 5 to 45 degrees of range of motion. So we changed the PT site and the patient agreed. I then went to a more of what I say as a center of excellence, people that have had a significant amount of ACL history and it actually worked with the BEAR technique and saw an immediate pickup in the range of motion. 0 to 90 degrees, then went to 105 degrees, but kind of flattened out at the 4-week mark. Wasn't one of those patients that really felt stiff, but definitely just had some maybe, whether it was some anterior adhesions or just didn't feel comfortable moving the knee to more range of motion. So I wouldn't call it the patient had an arthrofibrotic feel to the knee, but more of just a stiffness and a slow recovery. So at 5 months, for fear of not making further progression, I suggested doing a scope and looking at if there was adhesions. And what my feeling is, I never do just a manipulation under anesthesia, status post ACL reconstruction, or the restoration technique, because I want to get in there, lyse adhesions, and not break up any of the tissue, whether it's or stretch out the ACL reconstruction or the restoration. So I did a lysis of adhesions and then made sure I could get the most motion. So some warning signs here, obviously the PT considerations. At the first surgery, you could also see there was some synovitis there. Young female, fair complexion. Sometimes that presents with some of the things that we've seen in the office when patients tend to follow some stiffness. And so those are some warning signs, but also just here, slow progression with PT initially. And so I got a second look at 5 months, and this is the only second look I've had. I've had about 60 patients that I've done the ACL restoration with BEAR technique. But you can see here, vascular inflow into the ACL itself, and here, healing at the footprint site with stable as I was pulling on it. It wasn't pulling off. You could tell before as I pulled it away, it was bowing. And the interesting part here, I didn't see any evidence of any of the sutures that were there before. So after surgery, the interesting part about this, again, not an arthrofibrotic feel, and the patient immediately recovered quickly. Within 2 weeks after surgery at the 5.5 month mark, 120 degrees, got up to 140 degrees by 8 weeks, which is 7 months status post initial procedure. By 8 months, the patient had full motion, started hitting a simple fielding program, and by 3 to 4 months after, but 9 months status post the initial surgery, basically was returned to play. So interestingly, as opposed to an ACL reconstruction that really got arthrofibrotic, this patient actually got back on the right path fairly quickly. And you can see here, most of the time when I have an ACL reconstruction, if they are getting stiff, I'm scoping them at 3 months because they get really stiff and then they really suffer. Their quad doesn't build, they get inhibition and develop bad habits. And so I was able to wait longer in this case, but also we're able to make up for it on the end because it wasn't a true arthrofibrotic situation. So ended up it being in a good result. So this gets to my personal experience because I kind of didn't tell the truth earlier. My first real experience with this was actually this, and this is my wife. And so it's interesting whenever you have a family member that suffers an injury, it makes you rethink and question the mentality that you take into how you treat injuries. And so my wife, valgus knee, is not the best candidate from an ACL perspective, never has really spent a lot of time in the gym building quad bulk, things like that. So I knew that it was going to be a tough course after surgery. And so for me, the ability to have another option for her was very important. And you can see her injury. She was a true mid-substance injury, more of a Sherman type 3 injury. For her in particular, had one of the part of the ligament that was kind of coming forward, which was the more anterior medial portion, and the posterior lateral had a little bit more length to it. So a true mid-substance rupture. And you can see her here, probably 9 months after surgery, she was up here, and now she's back to doubles tennis, working out and happy with how she's doing. And no, she wasn't a skier, and she doesn't want to ever go skiing again because that was not in her passion project for her. But it was an interesting start for me, and this was really the first time I thought about, hey, I want a better option. I want another option. I feel like the utility of having more arrows in my quiver is very important to really truly give ACL injury patients options that are going to kind of give them the ability to get back to what's important to them and limit the complications that can happen that again are important to them.